displacing the kidney inferiorly, and there is fluid in the paracolic gutter, and you can see that the atelectasis and the pleural effusion from this appearance. So what do you think? Until now, I see all the comments that maybe there is something, but what else? What do you think about this? The uterus, yes. So what happened to the uterus? The uterus. What happened to the uterus if you describe it? You will say that the uterus is large, and then now the clinical question. What could be? Yes, bulky. So why the uterus is like this? So do you check the history of this patient? I think you need to check the history of this patient. So the history of this patient, maybe I can delay a bit, but if someone can suggest any history, what is the possibilities? Check this area and you can find some air loculi here. Yes. So what it could be? What happened to the uterus in this case? Can you suggest something? So until now we find retroperitoneal mass. Thank you, Omar, Umair, or Omar. Yeah, it can be post Caesarean section. This is the scar site of Caesarean section. Nice. So can be post Caesarean section scar and with some air loculi. Okay. And this patient, for one reason, I don't know, he did MRI, and you can see what is going in the T1 of MRI. So in this lesion, which is the retroperitoneal lesion, there is area inside this lesion with signal abnormality. What do you suggest is this high signal in T1? What it could be? Yes? Carol, can you suggest something? Suzanne, okay. So this area could be hemorrhage or fat. So you need what is called fat suppression. If you find this fat suppression now, what you suggest? Is it fat or hemorrhage? So it's not suppressed. This means that is hemorrhage. Nice. So when you find this area with hemorrhage, now try to collect the finding. There is intrahepatic something, lesion, retroperitoneal mass. So in the liver, what happened in the liver? Let's go back. The liver, there is intraparenchymal and subparenchymal hematoma. You can see the first image I will show you. Intraparenchymal and subcapsular hematoma, and in and around the liver, and there is a fluid, and in the paracolic gutter, and there is retroperitoneal mass, and we check the yes, Sarah, perfect. There is paracolic gutter tumor. Help, Muayyad, perfect. Amna, nice, exactly. This is what is called HELP syndrome. So HELP syndrome with hemolysis, elevated liver enzymes, low platelets, intraparenchymal and subparenchymal hematomas, perfect. And you know that you suspect cesarean section when you see the scar in the, and when you now check the history, you will find that this patient already, she is 35 years old female and have acute right upper abdominal quadrant pain and the collapse in the 3rd trimester of pregnancy. So yes, it's hard case, but when you find the hematomas, retroperitoneal, around the liver, liver injury, so all this you start to think about something else. And when you find that the postpartum uterus is bulky, and this patient did operation, then you are talking about HELLP syndrome. Yes. So the principal diagnosis would be HELLP syndrome. HELLP hemolysis, elevated liver enzymes, low platelets. Okay. So if you like to, what could be this right large retroperitoneal hematoma? What is the suggestion? What it could be? What is the site of this retroperitoneal? What it could be? It could be what? Yes, secondary to low platelets and DIC, disseminated intravascular coagulation. The retroperitoneal region here, which is the site of suprarenal gland. What happened in this region? Adrenal hemorrhage. Yes, exactly. So this expected to happen for this patient. Sure that the differential diagnosis, all what you mentioned before, that it could be, for example, hemorrhage in a tumor or whatever you mentioned, okay? The most important, the management. The management in this patient, supportive management, and maybe liver embolization because of the hematoma if the bleeding continue. You know that HELLP syndrome is hemolysis, elevated liver enzymes, low platelets, and severe variant of preeclampsia. As you see, it presents with subcapsular intraparenchymal hemorrhage in imaging. The typical that it is prime gravida before birth in the 3rd trimester. Okay, it's more common in the black females, 2nd, 3rd decades, and you see how it look in this case. Okay, don't forget it is important case. I wish that you enjoy it, and maybe you can need embolization if the bleeding continue. I think maybe we can finish with this last case. Okay. No, just mention that the adrenal, it could be this one adrenal hemorrhage, this retroperitoneal lesion. Yes. Just like explanation for what happened in this patient, as they comment to have this. Yes. So let's go to this case, which is 20 years, male. So there is lucent lesion in the midline of the mandible. And you comment that there is no fractures. Okay. And here clinician requests the CT and you agree for the CT. So this is the CT image, how you describe it. So there is a lytic lesion, mandibular lytic lesion. And when you describe it, you should say that like mildly expansile. And there is a cortical thinning. and there is cortical breaching or breakthrough. There is no associated soft tissue. Maybe there is there is breakthrough, but there is no soft tissue mass component. Okay. Let's go further. This patient did this study. Which is whole body bone scan, MDB. So you can note that there is increased tracer uptake within the mandibular region. There is no other uptakes, no abnormal uptake. Okay. Finally, in this case, when he did CT for his lung, or you check the system for the previous images, you check that this patient did CT for another reason, and you find this appearance. So how you describe it? Exactly. So nodules with thin wall cyst or cystic appearance bilateral in the upper lobes, and there is no pneumothorax. Bizarre shaped. So you are talking about Langerhans cell histiocytosis. And what you see in the mandible, it was xenophilic granuloma in the mandible. So this is the case here. It was easy one. So just to mention that the differential diagnosis of when you find in the mandible, it could be eosinophilic granuloma, multiple myeloma, but take care that if you did bone scan, it will be called in the bone scan as a typical one, and it will also be multiple lesions. Fibrous dysplasia, it have characteristic grounded glass appearance in the CT or the radicular cyst. It is around the tooth apex. The indigenous cyst, it is related to the crown of unerupted tooth. You remember this, the indigenous cyst. Ameloblastoma, the more common in the angle of the mandible. Yes. Brown tumor, you will find the criteria of hyperbara. Some others, like aneurysmal bone cyst, giant cell tumor, hemangioma, and simple bone cyst, it can be included in the differential diagnosis. If you find bilateral lung cyst, Langerhans cell histiocytosis, and lymphangioliomyomatosis, neurofibromatosis, and tuberous sclerosis. So all the phacomatosis, it can be like tuberous and neurofibromatosis, it can be involved. Honeycombing and cystic bronchiectasis and sarcoidosis. You refer this patient to specialized chest and maxillofacial opinion. I wish that you enjoy this night session, and I wish that the cases you like, and I wish that it can be of benefit, and hope everyone doing well. If you need anything, just leave in the group, and I hope that the group it can be more active and everyone can share something with benefit. Thank you, and salam alaikum. Back. Yes, Marwa, reaction. This is very nice from you, and let's talk as we usually talk. Yes, we talk about what is important for the exam in description, and the differential diagnosis and management, and finally, if there is any important notes for the MCQ issues regarding this case. Yes. So what do you think? Yes, tethering and carcinoid. So something nice to know, as you see, mesenteric mass with desmoplastic reaction, MITS, sclerosing. So I see that everyone agree that it could be this carcinoid. Maybe we just mentioned that it is in the location in the right upper quadrant, stellate appearance to the surrounding fat, so is important in description. And I am looking for, yes, Marwa, she mentioned about the bowel thickening. So you should comment in the bowel thickening, yes, for the exam and for the practice, that if there is any affection in the bowel or not. So you will take marks for this or not. And finally, you require to look for the arterial phase, yes, for the hypervascular lesion. You remember when we talk about the carcinoid as one of the typical neuroendocrinal tumor, you check for hypervascular metastasis in the liver. Perfect, Marwa. Perfect, Nermeen. Yes. So when you look for this, is important for the checklist of you in the exam. Okay. And let's, if there is, yes. So that's what you look for, the arterial phase. And now I think you see this and this and this. So there is multiple lesions in the liver. So you are looking for this metastasis. So now we are talking about small bowel carcinoid with hypervascular metastasis, liver metastasis. So it is carcinoid syndrome. Exactly, Ala. I agree with you. So differential diagnosis could be include metastasis to the small bowel, liver, or a primary small bowel carcinoma with liver metastasis, which is the typical case here. When you ask about the history for the MCQ issues, you are looking for diarrhea and flushing. So if he give you for the FRCR2A anything in the question about diarrhea or flushing or anything similar, so you are talking about carcinoid. Okay, so let's see this table about the causes of the desmoplastic reaction in the mesentery. So the first one, it will be the carcinoid, as you mentioned, small bowel metastasis. As Nermeen told us, lymphoma. Yes, I agree with you. Fibrosing mesenteritis and desmoid tumor. And when you find the hypervascular metastasis in the liver, so the first thing you think about it, it will be carcinoid, but also you can check for MRCT. MR, melanoma, M, R, renal, yes, CT, choreo, and T for what? T for what? I forget. T for teratoma, thyroid. Yes, thyroid, exactly. And I for islet cell tumor, exactly. So this is the most important vascular metastasis. Muayyad, yes, thank you. And Nermeen. So what it will be the further management, which is very important for the exam, the ectoriotide scan. Yes, it was before ectoriotide scan. So what is the new now? What is the you should mention for the exam reason? We mention it. What it will be before. Anyway, for the FRCR, referral to the endocrinal cancer MDT for surgical resection of the primary tumor or treatment of liver metastasis. MRI is very important, as we mentioned. Yes. So it will be gallium dotatate or whatever, gallium scan, 67, yes, gallium scan, which is more important now as a good tracer for tracing, for searching or localizing the neuroendocrinal tumor. And you, the question about this in the MCQ, or also for the, they will ask you, if this patient come to you, what do you expect in the PET gallium scan? It will take uptake the carcinoid or not? So typically it will take high uptake or in the PET. So I will just write for the in the chat. Maybe you can recognize PET CT gallium scan. What it will show you, is it positive or negative? I write for you. The question is, it will be positive for carcinoid or negative in this case? Okay. Should I show you something? It will be very positive, not just positive, very high positive, exactly in me. So for the neuroendocrinal tumor, it's very high positive, the gallium. It will be very high uptake, yes, okay? So for the FDG, which is this one, FDG, PET CT, it will be positive or negative? It will be negative, yes. So the MCQ, it will take uptake. Why? Because the somatostatin receptors, which is distributed for the neuroendocrinal tumors, it is present through the neuroendocrinal tumors, and which is the tracer for this will go will be positive for the somatostatin receptors. And the FDG work for the glucose metabolism, so it is different tracer. Okay, so it will be typically it will be negative. If he go more, he will ask you, okay, when it will be positive, it will be in highly malignant neuroendocrinal tumor, which is undifferentiated. Undifferentiated neuroendocrinal tumor will be, in this case, will be positive in PET CT, which is the regular one, FDG PET CT. Okay, is it clear? Okay, I think it's clear. So let's shift to another case. Just to mention that, yeah, there is also treatment through the somatostatin analog. If this patient can take treatment along the maybe, yeah, the regular treatment will be surgical resection, and maybe for liver it will be resection or chemoembolization or RF ablation. It depends in which yes, which number and location and so on. As you know, this carcinoid tumor is high excess of serotonin levels, and you know that we mentioned that flushing and wheezing and diarrhea, the most important symptoms for this. Okay, let's go for this case. The quality of this image is not very high, but let's try to find anything. So maybe if you are lucky, the lung is not clear. What do you think? But there is no pleural effusion, so there is clear, and there is no cardiomegaly, no cardiac enlargement. So the lung are not clear. So is it alveolar shadow or yes? It looked like alveolar shadowing, bilateral diffuse alveolar shadowing. In our case, it will be COVID now in the top differential diagnosis, but you will search for other bones, soft tissues, if there is any associated manifestation. Anyway, this patient did high resolution CT. Let's go and check what we can describe high resolution CT, how we describe it. There is no lytic lesions until now. So there is ground glass, interstitial, thickening, smooth. Smooth or nodular septal thickening. I think it's going with smooth. Yes, smooth septal thickening, and bilateral, sparing the periphery, maybe spare the periphery. Okay, and bilateral, smooth septal thickening, ground glass veiling with smooth septal thickening. So you are talking about, and it is alveolar affection. So it is talking about differential, including alveolar proteinosis. If it is proteinosis, edema, pulmonary edema, perfect, pneumonia, I agree with you, and bronchoalveolar carcinoma, alveolar hemorrhage, adult respiratory distress syndrome, hypersensitivity, perfect, Nermeen, and Ala, I agree with you, perfect. Radiation also, you can include radiation if this patient have, but radiation always it is follow the radiation board. Lymphangitis carcinomatosis might be, but they like to mention that this appearance is what's called crazy paving. So one of the most important to mention the alveolar proteinosis. Yeah, also drug related like amiodarone. So the further management will be lavage, and then going to the management and the diagnosis. So the crazy paving will be one of the most important alveolar proteinosis. Okay, let's just mention the differential diagnosis. The most important will be pulmonary edema and pulmonary alveolar proteinosis. You remember the batwing pattern, curly B appearance, pleural effusion. Here you don't have pleural effusion. You don't have this lamellar effusions. You don't have cardiomegaly. So all this against pulmonary edema. Sometimes it can be not cardiogenic pulmonary edema, so it can be also without cardiomegaly. Pulmonary alveolar proteinosis, non-specific, perihilar shadows, sparing the extremities. There is no pleural effusion in the typical one, and the heart size usually normal. There is also something like a pneumocystis canii, and also now you can involve the COVID-19. I think you can put it the first differential diagnosis now, especially without presence of pleural effusion. So you can involve the the COVID-19 as the first possibility. And you have sure that you saw many cases right now in any site. Okay, let's go to this case, which is starting with ultrasound. And you can see the ultrasound in this patient. And this is the thyroid or the neck. So how we describe it? Yes. So there is thyroid ultrasound. So what do you see? Our ultrasonography experts, Hayam, nice. There is nodule, solid nodule, perfect. Okay, perfect. And this nodules, hypoechoic lesions, the largest one in the left lobe. And maybe if you open color Doppler, you can see that there is something going through these lesions. So it is vascular, hypervascular. So hypoechoic solid nodule in the inferior portion of the thyroid lobe. Nice. And Nermeen, perfect. Lower lobe, yes. We have a lot of expert radiologists in the sonography, yeah, nice. And the Doppler, it is hypervascular. Okay. So until now, what do you like to do? you can suspect thyroid nodule or maybe parathyroid. So if it is parathyroid, I think you will go to do scan like this one, which is, which type of scan this? Technetium system EB scan. This one after 5 minutes, then after 20 minutes. So what happened in this case? You can see that there is physiological uptake in the salivary glands. Yes, and also in the thyroid gland. But you can see that there is much focus increase in the left side of the left thyroid loop. So let's see what happened more. This also physiological. Okay. So after 2 hours, there is retention of the tracer here. Yes. Localized in the inferior aspect of the thyroid, left thyroid loop. When this patient did SPECT CT, which is CT with special scan, which like PET CT, but is like type of tomography, which have focusing in the thyroid gland with reconstruction, so you can see if there is any high uptake with anatomy, with anatomical background of CT. So I think now everyone, if the system may be giving, technetium system may be giving this appearance, you are talking about parathyroid adenoma, as you mentioned. Yes, so system may be, they like parathyroid. Okay, so until now we can just say that it is it is parathyroid adenoma. Yes, that's good. So what do you think? What do you like to do? So avid persistent uptake in the left thyroid loop, parathyroid adenoma. Okay, I see Marwa, Nermeen, Ala, perfect. Hiba, nice. So parathyroid adenoma differential diagnosis. Yes. What else? What do you think? If I give you this, yes. Yeah. Look for the renal and the bone. Why to the renal and the bone? You should have a scenario. When you have parathyroid adenoma, you will follow the bees. What is the bees? The bees. Yeah. What it could be the bees? Try to remember. Yes, exactly, Abbas. Perfect. Search in your mind about that the examiner want you to remember the men. Multiple neuroendocrinal syndrome. Yes. So when you find adenoma, parathyroid adenoma, or you find the examiner trying to give you a key that is parathyroid or hyperparathyroid, so try to remember the men. So you will search for the adrenal. So for example, you require, if this patient have any CT, you will look for the adrenal. If this patient have pheochromocytoma or adrenal carcinoma or whatever. Yes. So multiple neuroendocrinal tumors, and you will search. Let's go and see if this patient have any images that could help us to figure which type of men we have. So which type of men we have? Now you can mention. Yeah, it could be men type 1, multiple neuroendocrinal tumor consisting of parathyroid adenoma and right adrenal lesion, which could be pheochromocytoma or carcinoma. So which one could be pheochromocytoma or carcinoma? Which one you think? Ala? Okay. So what is the difference? Do you expect that the carcinoma will take uptake or not? Let's go to the again to the scan and see which one take uptake. So you see that the liver have physiological uptake, yes, and there is no any abnormal uptake in the right adrenal. So it's less likely to be pheochromocytoma. It is likely to be more likely to be carcinoma. Yes. So it is more likely to be carcinoma because it doesn't have uptake in this scan, which is referred that also the liver have physiological uptake, so it is not going to be. Let's see this, which is MIBG. Yes, I don't show you now. Let's go and see which one. You can see that the MIBG he did this scan to differentiate which one. It could be pheochromocytoma or carcinoma, yes. And he did, you can see the liver have physiological uptake. And the right adrenal, it doesn't have uptake that in the MIBG that give you that it could be pheochromocytoma. So the lack of activity in the right adrenal in the MIBG scan prove that this couldn't be or unlikely to be pheochromocytoma. So it will be carcinoma. Yeah. The management in this case will be correlation with serum calcium, parathormone, metanephrine, catecholamines, serum calcitonin level, sure thyroid ultrasound to exclude the medullary thyroid carcinoma, surgical referral, staging, and family history and genetic referral. Why genetic referral and why family history? Because men type 1 is like autosomal dominant condition. So family history and genetic referral is very important in this case. So what is men type 1? Parathyroid adenoma or hyperplasia, pancreatic islet cell tumor, anterior pituitary tumor, and associated with adrenal cortical tumor like adenoma or carcinoma, like in this case, and other like facial collagenoma, lipoma, and so on. Okay. You know that as for the exam, also for I see that everyone know it already. That in the ultrasound, when you see something related to the inferior ball, like this case, so below the thyroid gland, neck mass below the thyroid gland. So this is the thyroid, and this is could be the lesion which is linked to the inferior ball. So it could be parathyroid adenoma, or could be thyroid nodule, or lymph node. Yes. And again, because I see question from Ivan. Okay. The pheochromocytoma in the MIBG, If take uptake, so it is pheochromocytoma. If it doesn't take uptake, like in this case, there is no uptake in the right adrenal, so this means it is undifferentiated. So when it is undifferentiated, it will be carcinoma. This is the when the tracer come to the tumor which is differentiated, it will be the typical one, like the case of carcinoid, as we mentioned from few minutes. Here, the same. When the MIBG go to the differentiated tumor, so it will be pheochromocytoma. So we don't have any uptake here, which is MIBG, and this patient doesn't have any uptake, and already you can see the uptake, physiological uptake of liver is okay. So this means that there is no problem with the tracer. So now what it could be, it should be carcinoma. Is it clear?
مصطفى
I hope
تعرف
that
صعبة
fine. Okay. Let's go to
ايش
the
فكرة ثانية
next case. Okay. We have like 1 minute if you like to take a
Okay.
rest before we go to the
Yeah.
next case, which is difficult image, but okay. This baby, they make for him something like fluoroscopy in prone position. So this is fluoroscopy image taken for baby 15 months, and he have this in prone position. Yes. Okay.
ترى مصطفى
Take
تعرف طرفة ثانية
a rest for 1 minute before we go to the second session, and I wish I can show you some bed city cases today, inshallah. Yeah, the image is not clear. I agree with you. Let's go to the ultrasound. I will show you this, the ultrasound now. After this patient did the fluoroscopic image, he did this ultrasound of the upper abdomen. I think is easy case. So okay. Okay, so there is yeah, intussusception, exactly. Soft tissue target, bullseye sign. So the echoic ring represent the wall of the intussusception, yes, and peripheral hypoechoic ring represent the wall of intussuscipient, yes. Central hyperechoic area represent mesenteric fat, and internal hypoechoic area in the intussusception, yes. So there is maybe also I can show you the Doppler image when he did Doppler ultrasound, yeah, in the ultrasound, yeah. So there is central vascularity with Doppler color flow imaging, and there is no fluid, is important to mention. So let's go to the fluoroscopy, trying to describe what it would be in the image, just to see how we can describe it. Lack of gas in the right side of the abdomen. There is impression of soft tissue filling defect in the mid-transverse colon. The descending colon is, I agree with you that is not clear. Descending colon is collapsed. There is some dilated central small bowel. And the most important to mention in the description, that there is no free air demonstrated. Idiopathic ileocolic intussusception would be the possibility. There is no differential diagnosis. The management in this case is important for the exam that you mentioned. They like to ask you about the reduction. Yes, the reduction. So reduction using air or gastrographene. The contrast in the absence of any contraindication. The most important contraindication here, it will be air, presence of air, perforation or shock or peritonitis. They like to ask you in the MCQ, for the MCQ issues, about the age. So the age of this patient will be between 6 months and 2 years. So less than 2 years, not more than 2 years. Okay. And the most common site, again for the MCQ, it will be the ileocecal valve. And usually there is lead point, but some cases there is no lead point. The most common lead point that they like to ask about in the exam, it will be Meckel's diverticulum. Don't forget it. Also polyps, duplication cyst, and appendicitis. They like to ask in the FRCR about the reduction. And the most important, the contraindication of this, it will be presence of air, peritonitis, perforation, shock in the X-ray. Okay, let's go to the next case. Which is a much easier one. Try to describe. So this patient have the first look of this image, have something. Yes, splenomegaly. Yeah, massive splenomegaly. Exactly, Heba. Perfect. So the most important to mention in the description in this image, splenomegaly. And if you find splenomegaly, you will search for lymphadenopathy, liver lesions. So you should comment clearly that there is no liver lesions or there is no lymphadenopathy. Sure that one image is not enough, but you should know what to comment in. Okay. He give you sagittal image. So the bone looks intact, is not bone window, but you can note something in the spine, what it could be. Increased density, perfect. So now splenomegaly with increased bone density is give you clue for the exam, for the MCQ, for the about what is called myelofibrosis. This is very nice from you. that to think about myelofibrosis. So low signal in the bone marrow, which is less than the disk space or the disk. If you check the disk and you check the marrow, you will find that the signal of the marrow is less than the signal in the disk. So decrease bone density also in the MRI. Maybe you can say signal intensity better, and I agree with you. And so there is the reverse of the normal marrow. And most important to mention, the disk space are preserved. So this means that this patient have bone marrow replacement or infiltration. Differential diagnosis with myelofibrosis will include, yes, low signal changes in bone marrow T1 and T2, myelofibrosis, leukemia and lymphoma always present, and metastasis. Then you can put anything else like multiple myeloma, hemosiderosis, thalassemia, sickle cell anemia. So blood diseases in general. And if you find massive splenomegaly, you put the myelofibrosis as first impression. But also there is another like leukemia and lymphoma, and you will search for lymph node and any liver lesions or extra lymphatic infiltration. Gaucher disease and malaria and something like this, you can remember it, or maybe you don't like to mention it. Anyway, diffuse osteosclerosis, myelofibrosis, metastasis, osteopetrosis. So in childhood, I think it will be osteopetrosis more, and also renal osteodystrophy. So this is the major questions in the exam if you find splenomegaly. The management of this patient will be hematological referral and bone marrow biopsy. You know that the primary form of myelofibrosis, that it could be a precursor for polythalassemia or even chronic myeloid leukemia. They like to mention that it is in the pathophysiology of myelofibrosis that maturation, abnormal maturation of the RBCs and the granulocytes, and this patient could develop gout and renal colic from the hyperuricemia. The most important in management, bone marrow biopsy. As we mentioned, it is one of the most important causes of diffuse osteosclerosis and bone marrow replacement. So there is replacement of the normal marrow. The treatment of myelofibrosis, what it could be the treatment? Yes, bone marrow transplantation, exactly, Nermeen, perfect. And other treatment like steroids, androgen, splenectomy, and so on. Just I'm checking if there is any important notes to talk about for the MCQ. You know that already you can see sometimes something called like marrow inversion, which is tricky for you to differentiate it from the bone marrow replacement. So sometimes there is decreased signal intensity, but it doesn't reach to be less than the disk space, the disk. So, for example, if this patient have stress or smoking, or any medication. Sometimes he have something called red marrow conversion, but it will be still less. It will be still more than the skeletal muscle and the disc space. The disc, yes. So you can differentiate between both. Okay. Also severe anemia. Perfect. Yes. Let's go to this case. Typical case for the exam. Yes, Hayam. I see Hayam, mashallah, she's very active today. Okay, nice, mashallah. Ala. So when you find, like, let's describe destructive process happen, involve the nose and the paranasal sinuses. So destruction even include the hard palate. Yes. Nasal septum, which is here. So this destruction, also the turbinates. So there is complete destruction of these issues. There is small soft tissue thickening here, also in the left maxillary sinus. So maybe post-operative, maybe, but I agree with you that if you want to describe differential diagnosis, you will put Wegener sarcoidosis, causes of septal perforation. I see much, yeah, cocaine nose. Okay, nice. Okay, there is expert in cocaine. Nice. Okay, I agree with you, Muayyad and Hayam. Trauma. So many causes. Yeah, I agree with you. So destruction midline sinonasal process, it will be Wegener. One of the important causes, Wegener. And don't forget also the tumor, like lymphoma and the fungal, exactly, Marwa, and the fungal sinusitis. Yes, it doesn't have to be neglected because it's very important cause, invasive fungal sinusitis. And finally, the cocaine. I agree with you. So the Wegener, fungal, lymphoma, and cocaine. Okay. Sure, if I show you this now, which one you will put the top of differential? It will be Wegener. Perfect. Yeah. Why Wegener? Because it is type of granulomatosis that it affect the lung, and you can see that there's cavitating lesion in the right upper lobe, and you can see that there is soft tissue lesion or mass in the left upper lobe adjacent to the hilum, and there is some retraction here, pleural aspect. You can see here reaching the pleura, so it looks like a mass. So you'll check for lymphadenopathy, if there is any lymphadenopathy, any collapse or any effusion. This is important for your description to not lose any marks. In this case, it's very easy case. So sinusitis with destruction and with lung affection, you are talking about Wegener, or as we mentioned, fungal sinusitis again, invasive type, like aspergillosis, cryptococcosis. I see TB, HEPA, perfect. Also, it can involve TB. It check for both kidneys, perfect, Muayyad, nice. And metastasis, also it can be squamous cell carcinoma, and so on. It can be present with necrotic lesion or cavitating lesions. Just a moment. Okay. Septic emboli and rheumatoid, perfect. Bronchogenic also, yes, I agree with you. So you have wide differential diagnosis, but for the exam, they like to show you this Wegener when you find nasal destruction with cavitating lesion, you will put Wegener in both sides of the differential diagnosis. Destructive midline sinonasal process and thick-walled cavitating lung lesions. Don't forget them. The further management in this case will be NT referral, biopsy, sure, and chest referral, and maybe guided biopsy from the left. For the MCQ, as Muayyad mentioned, check for the renal function, check for kidneys, and something called in the lab, something called, it is positive what in the laboratory? They like it in MCQ. C Anka, Amna, perfect. Welcome back. Our star. Yeah, Amna. So C Anka positive, perfect. So this is the MCQ classic positive for C Anka. So you will ask in the laboratory. If you find it, then it is case of Wegener granulomatosis. So pulmonary affection with sinuses, you are talking about, yeah, have positive C ANCA support the diagnosis, but is not necessary to make the diagnosis. I mean, if you find it in the laboratory, it will be typical, but is not necessary. The treatment of Wegener in general will be steroids and something called cyclophosphamide. This patient, you will search in the trachea. So you will search for the trachea for what do you think that maybe you can find in the trachea, but is not in this case. Tracheal what? Tracheobronchial stenosis. Yes. If you find stenosis, then this patient will need intervention with stent. So you should check for the trachea if he have stenosis as well or not. Also, in the follow-up of these cases, you need to check for relapse if this patient have any type of relapse. Okay. This is a case of Wegener granulomatosis, typical for the exam. I think we have to take this as a last case, then we shift to another type of questions. If this patient come to you, yeah, with ultrasound in the liver, as you see, so how you describe it? Liver, yes, left lobe lesion, focal lesion in the liver. Yes, this is post contrast image. So the first image with non-contrast and the second image post IV contrast. Exactly. So this means that this take contrast hyperechoic and it have focal bulge, contour bulge, and it have something inside is hypoechoic. I think you are agreeing with me that we think about FNH, one of the good differential. Nice, Muayyad. Nice, Ala. Yeah. So in the T1, you know that this is T1 image, and you can see that also in the central area maybe have low signal. In the T2 image with fat suppression, you can see that, yes, the central scar have high signal in T2, so low signal in T1, high signal in T2. And in the post-contrast images, in the arterial phase or the late arterial phase, you can see that there is enhancement, but there is, in the delayed phase, you can see maybe some delayed enhancement. So this is typical case for focal nodular hyperplasia. There is uptake in the central scar in the delayed phase. Less likely to be adenoma because it's clear that you can see the scar here and is not typical for adenoma. It could be like fibrolamellar, but there is no feature of malignancy or local invasion or lymph node metastasis. It need to discuss with the MDT team in the management, so MDT referral. And you will ask in the history about oral contraceptive pills and maybe discontinue this oral contraceptive pills. And you know, the like in the MCQ and the exam, all type of exams, you will find FNH. So I think everyone know it. Just remember the difference between the fibrolamellar. Usually it is larger than this one, is more than 12 centimeter and more heterogeneous in the signal. The scar usually be low signal intensity in the T2 if it is fibrolamellar. And also you will find like multiple lymphadenopathy or invasion. Okay. So this about 7 cases. I will show you just few cases like short type. I wish that you can enjoy. So this case, just a short case. What do you think? Chiari 1. Why Chiari 1? Just describe shortly. Yes, syringomyelia. And what else? There is tonsillar herniation. Yes, perfect. So there is tonsillar herniation with syringomyelia. You can check in the axial images for tonsillar herniation with syrinx. And you know that there is, sorry, there is what is called a Chamberlain line. It should be less than 5 millimeter. The dens project above like 9, so this means that it is more than usual. So this means that there is also basilar invagination, right? and this line also, which is this line and McGregor sign, yeah, less than more than 3 millimeter in Chamberlain and 5 millimeter in McGregor, right? I pronounce it in good way. Anyway, two lines. Yes. So this one, it is carry one, typical case of carry one. They like it in the exam. You will find it as spotting case, typical case. Just read the comment before we shift to another case. Okay. Just the internet connection is not very high. Checking the okay. Easy one. Easy one. Yeah, perfect. Ala. Left hyperdense MCA sign. If you compare it with other vessels, you will find like left dense. Until now, there is no infarction, but it is yeah, MCA sign. It's very dangerous sign for infarction. Let's show you this case also. Subarachnoid hemorrhage, peripontine. Yeah, let's live in peace. So it is you require to do CT angio. Sometimes it's normal. Sometimes you can't find the source, like it is aneurysm and so on. But you can see that the non-contrast image, you can see the hemorrhage very clear. So subarachnoid hemorrhage. So easy cases in the end of session to enjoy your night, to not have any nightmares. Maybe just one or two cases which give you good impression before you sleep. Just open. This is typical case they like to show you for the nodular leptomeningeal enhancement. Perfect. It could be carcinoma, and it could be inflammation like meningitis. When you find this appearance, what do you think about this dot? So it could be metastasis, carcinomatosis, and finally it can be inflammatory like meningitis. Look in this area. What do you think about this batch? High signal intensity, and there is obvious restriction of diffusion here. So this is diffusion image, and you can see the restriction. Short case, there is infarction. So this infarction, which is the distribution of Bica branch. Perfect. Bica, exactly, Marwa. Nice. Perfect, Muayyad. There is Bica location. So there is complication of the meningitis or this enhancement. So this patient developed Bica infarction. Perfect. Nice. Let's go to this case. There is vascular compromise. And this case, you can see bilateral, how we describe it. It says increased lucency or decreased lucency. There is decreased lucency. And if I show you the spine and the pelvis, what do you think? I think there is also patchy involvement with decreased lucency. And if I show you more and more, yes, so there is disseminated focal region of lucency. So in background of osteopenia, and there is some rib fractures. So you are talking about multiple myeloma as a first possibility, especially if the age is supporting. So multiple myeloma case, differential diagnosis will be metastasis, and multiple myeloma will be the best differential diagnosis. Widespread with multiple myeloma, extensive type. Okay? There is no nightmares at night. Enjoy your sleep. And maybe just last case before you sleep. So it is this one with this appearance. Who will be the last star in this night? The big star. Okay, let's move. Maybe we should move to show you the extension. Yes. Our big star, who will be the big star for tonight? We can give him like one chocolate, and if you like the dark chocolate, I can give him one online. So which one? It's spotting case. Not very big spotting, but I will show you maybe this one. Okay. Okay. I know is not easy, but yes. Hassan. Hassan. I think it will be Hassan. I think it will be Hassan. This is the delayed image. Yes. Aneurysm. And so Hassan will be the first. Second will be Ala, because he mentioned first. So this one, it is aneurysm. This is the non-contrast image. And you can see there is mass, heterogeneous attenuation, and there is compressive effect in the brain and brainstem. And the most important, if you didn't mention, you will lose much marks for the exam, and you lose the patient. If it is a real life, the hydrocephalus, don't forget it. And if you should do contrast image, sure. In the arterial phase, you can see that there is dilated artery and there is hematoma inside. So basilar artery tortuous, elongated, and thrombosis inside, aneurysmal thrombosis inside the aneurysmal dilatation, and in the delayed phase as well. So this case, it is giant aneurysm. So Hassan first, Ala second for this night, inshallah. If we meet, I will give you the dark chocolate. If we didn't meet, so you can buy one and send me the picture. Enjoy. And Ala, also for you, like one dark chocolate, if you like it. You can take one normal chocolate. Anyway, I wish everyone enjoy, and we can inshallah receive your comment in the group, in YouTube, anything. Have a good night. Assalamu alaikum.